Hello, welcome to another live members only tutorial. Today we are covering everything biopsy. We're going to start with how to mark up your lesion, and then we're going to go on to do some excising on some of our models, both face and body simulators. Before we get started, you need to know that we have our members only area on the website, which is going to replace the members only area on YouTube. So if you are not registered on the website, don't let your YouTube subscription renew and join the members only website area at www.medsyncltd.com/resources. The link will be in the description. That's medsyncltd.com/resources. It's going to replace the members only area on YouTube. And why? Because we just can give you more clinical cases, guidelines, PDF textbooks, one-to-one training, group sessions. It's all going on there. So when we're marking up our lesions, we need to be really precise. So let's say this is the area of problem. Then often around these things you have a margin of unstable skin, often just doesn't look quite healthy, and often these things are not regular in shape. You need to incorporate all these things, especially if you're thinking it's a skin cancer. You first want to start by defining the margin of the problem. I often do this with just dots around the area of unstable skin and the problem. And then you're going to want to add your margin, and depending on what you're excising will dictate your margin. So in the UK, BCC, SCC, melanoma, your common things. Start with the basics. You're doing a diagnostic biopsy. All diagnostic biopsies are a let's zoom out a little bit. They're a 2mm margin with a cuff of fat. That's for diagnostic biopsies. If you're doing a therapeutic excision and it's a BCC, we say it's 4mm for low risk and 5mm for high risk. Then we've got SCC, which is squamous cell carcinoma, and that's going to be either 4mm, 6mm, or 1 centimeter. Low risk, intermediate risk, high risk. These go down to fascia, the SCC, the next fascial plane. These will go down to the next clear plane. Typically your low risk BCC, basal cell carcinoma, will go down to a cuff of fat because they're not likely to invade very deep. Your high risk may be more invasive, so you need to go to the next clear plane. Alternatively, they can have Mohs surgery, which gives better diagnosis of histological clearance. But your diagnostic specimen for anything is 2mm with a cuff of fat, but that's also what you do for melanoma. So you always get your ruler and you just mark your 2mm margin with your cuff of fat. So let's just say that's here. I tend to do a longer line for that, and you follow the contour. Often I'll do it on the bits which either, if it's irregular, I would do this bit first, this bit, one straight bit there, one bit there, there, and there. So it should follow the kind of contour of the lesion. So once you're there, you need to also then assess whether you can close this primarily or not. Things that will decide that essentially is, let's say that's my margin, is where the laxity is. So on the limbs, you want to close things axially or longitudinally. So that's in line with the direction of the limb. So legs, arms, you close them axially. Why do you close limbs axially? Because the laxity often is circumferential, so you can close in this orientation without much tension. The lymphatics run longitudinally, so you don't tend to get too much edema, and you preserve these if you close them longitudinally, and reconstructions are often better when done in the axial direction as opposed to the transverse. But sometimes you have to go a bit oblique, but most of the time you aim to do them longitudinally on the limbs, so arms, legs, hands. So oftentimes you mark this area, and then we talk about making things into an ellipse. We often talk about the ratio of 3:1 in terms of making an ellipse. So if this distance is the 1, the width, the length needs to be 3 times this. So if we measure that out, that is, well, according to this, 5.5 centimeters. So we're going to be, to get enough to avoid the dog ear, going to be 3 times that distance. Obviously this isn't to scale, so you're going to be something like that, and then something like that. So this length needs to be 3 times that distance. What is the purpose of the length? The purpose of the length is to reduce the risk that this edge bunches up and this edge bunches up. So if I was just to excise this as it is, there'll be what you call a dog ear here and a dog ear here, what you call a standing cone or a dog ear. So to reduce that risk, because we know it's going to occur, you incorporate the ellipse here, you incorporate the ellipse here, and roughly this distance is 3 times this distance, which is 1. Loosely. So, as we said, your 2mm, if you're doing a diagnostic biopsy, it's 2 millimeters with a cuff of fat. You mark your lesion with the unstable skin around it, draw a margin around that, and then add the 2 millimeters onto that margin. Whether you excise as an ellipse or not depends on whether you're likely to get a dog ear. Most places you are, so you do that. BCC is either 4 millimeters or 5 millimeters. 4 millimeters is the low risk, 5 millimeters high risk, and SCC is either 4 millimeters, 6 millimeters, or 1 centimeter. That's low risk. Got doctor's handwriting, haven't I? That's intermediate risk, and that's high risk. This is to fascia. It's the depth in which you excise to. This is with fat often, but when it's high risk, you may need to go down to a deeper plane if you think it's more invasive. And a diagnostic biopsy, but also for melanoma, so any pigmented lesion, you do a 2 millimeter margin with a cuff of fat. For melanoma, you want to get a Breslow thickness. This is a Samsung Galaxy Ultra Tab. Affiliate link in the link below, in the description below. Let's move on to our models. We're first going to start with the skin patterns. I'm going to show you how I do my excisions in reality. How do we start? So let's say we have this pigmented lesion here. It's irregular, it's got different colors in it. The diameter is greater than 7 millimeters. Patient complains it's bleeding, itching, some tingling in it. We're concerned this is a melanoma. So you want to add 2 millimeters. We try to measure with a ruler. Next size as it is. Because it's going to be on a hand, I'm going to mark it as an ellipse. Remember I said that you want them to be longitudinal, so the limb is running this way. I'm going to excise it longitudinally so I don't get a dog ear. So the dog ear will be here and here, the standing cone. I'm going to extend it so that I can just do it all in one and close it and stitch it. You have to think about how you're going to close it. This is going to be the point of most distension or gapping. So you want to think about how you're going to close these layers. I would close this with some deep dermals and then some interrupted sutures. Practical skills now. Mounting a blade. You're doing this in the minor ops procedure room. You've got this groove here, needs to line up into that groove here. This is a 10 blade, but same for a 15. And this is a 3 blade handle. For bigger blades, you use bigger blade handles, but 10 and 15 go into the 3. This angle here needs to align to this angle here. Angle it safely, away from you, away from the patient. Align the groove and push. And it's gentle. Take it off, turn it around, lift off the groove and push. But we want it on, so we're going to push. MedSync needle holder, tungsten carbide. You can get this from the link below the MedSync website. So you start, if you're doing these are practical tips now, so pay close attention. If you're sitting there with you're sitting on the inside of the patient, their arms aren't on the arm table, you need to decide where you're going to make your incision first. You could make it on the top, but gravity will make the blood run this way and cover your markings at the bottom. So actually you want to start with the inferior line, so blood runs down, but you can still see your superior line. If you start at the top, blood will run down, it will cloud your field, start dabbing, it gets messy. So let's say this is the top, this is the bottom. I'm going to start with the inferior line, making any incision. This is a precision grip, which is this grip. You can see our videos on incision if you want to really rehearse that between incision and power. Perpendicular to where you're going to cut. So don't cut with your fingers here because you're going to cut your finger and you'll be the next replant. You want to go in between, put the counter traction in between, so my fingers are applying traction away from where I'm cutting. Use the belly of the blade, not the tip. Release the corner and cut. Move your hand down as you go and cut, and move your hand down as you go and cut. That's the bottom line. And then I'm going to do the same at the top. Cut, 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 and move. Depending on what body part you're at, the thickness will vary. So if I'm on the back, I know that there's really thick dermis and a lot of fat. So compared to the back of the hand, really thin dermis very quickly get down to the extensor tendon, so you don't have to put so much pressure. So often I will score the outside first, put the traction and see if I'm deep enough. Here I believe I actually am deep enough, so now I'm going to lift up this skin. Pay close attention to this. Start in one area and lift it. I want to go to a cuff of fat, so I want to see the yellow with a cuff of fat. I want it on this skin pad. I want to take it with the pink and see some yellow underneath, which we'll say is the deeper tissue. But if it's the other way around, the yellow would be the pink would be my deeper tissue. But here my plane is yellow. I'm going to put tension on this hand, and it's this hand that actually does most of the work. And all you do is sweep from one side to the other. You don't do a little bit, little bit, little bit. Put traction on this hand, really pull up and just sweep from one side to the other. And it should give you a reasonably even plane. Release the corner, and then you put that there. So if you're going to close it directly, this is really important. If you're going to close it directly, you don't have to put a marker stitch on the specimen. You should know that before you start. If you can't close it directly, put a marker stitch in. So that's your 2mm margin with a cuff of fat. I'd put some deep dermals here, 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 and here, and then some interrupted. If you think you're going to have to come back and excise this wound because it's melanoma, there's no point doing a beautiful subcuticular, but you can if you want to. If you want to learn how to do suturing wounds under tension, check out the videos on suturing big holes. So that is tips for diagnostic excision. We've talked about therapeutic excision. You mark them the same way, the lesion with the indurated area or unstable skin, add the margin, and then determine the depth. We talked about putting counter traction on, making your incision on the lower line, which is lowest based on gravity, and then the top line so that you do not skewer your field with blood dripping down. Same for on limbs. You close wounds on the limbs axially, so longitudinally, because the laxity of a limb is circumferential, so you can draw on that to close your wound. Lymphatics run longitudinally, structures run longitudinally, you're less likely to injure them if you're cutting along them rather than perpendicular to them. And reconstruction is easier if you do it in this fashion. So then we come to special circumstances. The face, the MedSync face sim. The face differs compared to other body parts because you don't excise things as in the lips. On the face, you have muscles working in different directions. You have from the cheek zygomaticus, major, minor, orbicularis pulling up, zygomaticus pulling up, levator pulling, orbicularis closed. Often you find that actually, if you just have your lesion here and mark it as it is, the shape as it is, and you excise it as it is. I'm going to start on the lower line because of gravity, as we discussed. You want the blood to drip down. You will find that the laxity of all your let me just excise this. Multitasking is not easy, as I'm a simple human. So you will find, one, they often become circular, but two, you don't actually get dog ears. What you find is that you can manage to bring the different parts together. So you excise on the face, excise it as it is, bring it together, and if there's a dog ear like there would be here, you can extend it minimally as needed. Yeah? I should probably show you how we do dog ear excisions. So let's do that. Let's try and do that. So I put in some deep dermals, but this is not that task. If I want to do deep dermals, check out the MedSync videos on that. But I'm going to show you how to do a dog ear if I can create one. So we talked about 3-to-1 to avoid dog ears. I'm going to show you how to do a slip knot. Bring it through. So retension the wound without having to undo it. So the dog ear would be at the top. If it would be right here, this would be the dog ear. So the way you address a dog ear is you make an incision on one side, so I don't cut my suture. Let me use a scissor actually. And then wherever you have the excess, you just overlap it and trim it off. So the excess is there. And trim it off. And then you just place your stitches in between, like so. There and there. But this is still not a 3-to-1 ellipse. The dog ear would just be on one side. I've extended it maybe 0.5 centimeter. Seeing where the overlap is and cut off the overlap. Whereas if I had planned an ellipse, it would have been into the eye and way down here. The scar would have been unnecessarily long. On the face, excise as is. See where close it. If there's a dog ear, extend it a little bit, pull it over to the overlap and cut off the overlap. So the face is a special circumstance. The final thing to talk about with biopsy is punch biopsy. So it's a really useful tool for if you are, it's a really useful tool for either biopsying small things or excising small things, because if you've got a 2mm lesion, you get a 5mm punch. That's a 3mm margin. It can often do what you require. But the key is to notice this. All of this punch, this is a 4mm punch. Why? Because it says 4. All of this doesn't need to go in unless it's somewhere where there's thick skin. So on the face, you just need to put down to here maybe. On the back, maybe you do need to go down to here because the dermis is really thick. You need to get some fat. But the depth in which you push this in really just depends on where it is. So you have somewhere on the face, you just want to put it on. I say give it some pressure. Twist it, twist it, twist it, twist it, twist it. It will go through. And then one of two things will happen. Well, this is still there, but often it's like that and it will be a bit attached. So what it tends to do, let's do it on the skin pad. I think that's probably going to give a more realistic. What you'll tend to find is if you just do your punch there, it will pop up like that. And if you just, it will start bleeding, so you're going to have to be quick. But you see your fat plane, I often will either get the scissor and just cut at the base, like so. And you can kind of work your way around it. But just getting at the base. Why am I making the effort not to hold it too much? Because you find, so what I've done here, mistake number one, is I haven't gone all the way around with the punch circumferentially. It hasn't released there. So that's a good thing to have shown. You can put the punch right back over and finish off the job. Make sure you give it a good twist. And then you've got a full release. But it can get a bit messy if you do that. And then cut the base. And then what I tend to do is lift up from the base. Try not to squeeze like this because you crush the specimen. Just put it in at the base and lift up. And when you're lifting up, you can then cut the base. And then that's your specimen that you want to send off to the lab for diagnosis. And it's not crushed, it's just as is. So a reminder, you can put the skin under a little bit of tension, rotate till it goes all the way in, but rotate all the way around so you release 360 and then it pops up. You go in under the base, you cut, you might want to go from different angles, you cut, and then you can cut, and then lift your specimen up from the base so you don't crush it too badly. If you can, you might be able to release a bit more. And then finish it off. But the specimen remains uncrushed. And then you send it off to the lab. And obviously you can, it's really, really oozes, so you can do some quartering to the base, but often I just do a mattress. You also I do a mattress suture as well to close it, because everything heals quick if you bring the edges together. So we have talked about biopsy. We've talked about diagnostic biopsy, excision. Let's summarize, because it's good to do that. So we've talked about let's So I'm sure there's a quicker way to do this, but you know, tech novice here. I think it's good to add some writing to vary things up. So we've talked about, it's too thick. Diagnostic biopsy is 2 millimeters with fat. So you mark the lesion and any unstable skin around it, and then add 2 millimeters to that. Then we've got our therapeutic biopsies. These are excision biopsies. They are with the intent to cure. We can split them into different categories. Skin cancer, essentially. BCC, which are either low risk or high risk. These are 4 millimeters with fat. Just the cuff. High risk tend to be 5 millimeters to the next healthy plane. That could be take all the fat, go down to fascia, go down to periosteum, depending on where you are. SCC can be low risk, intermediate risk, or high risk. And that's based on the size, the risk size, location, whether it's recurrent, the histological subtype, if you've biopsied it beforehand, if the patient's immunocompromised, several different factors. Low risk, you take off with 4 millimeters. Intermediate risk, you take off with 6 millimeters. High risk, take off with 1 centimeter. These are all down to the next fascial plane. But if you're going to do a skin graft, something on top of it, you may as well do it to the deepest plane that will take a skin graft. Melanoma is different. Malignant melanoma, you need to get a Breslow thickness before you come back and do another excision. So the first surgery is 2 millimeters with fat. Then you get the Breslow thickness. If it's greater than 1 millimeter, you take 1 centimeter. If it's less than 1 millimeter, you take 1 centimeter. If it's greater than 1 millimeter, you take 2 centimeters. They are both down to the next fascial plane. So melanoma, you take a 2 millimeter margin biopsy with a cuff of fat. You get the Breslow thickness. If it's less than 1 millimeter, you take a 1 centimeter margin. If it's greater than 1 millimeter, you take a 2 centimeter margin with the fat down to the next fascial plane. I hope that's been really, really useful. We talked about the face as a separate area where you take it out as it is and then extend the wound. If there's a dog ear, do not prophylactically take out a dog ear on the face because you will take out too much skin. Do only what's necessary. As I mentioned, our members area on YouTube is coming to an end. We are now providing this on medsyncltd.com/resources. Link is in the description because we can do PDF textbook clinical cases that are not censored by YouTube. It's got all the live tutorials. These weekly lives will be hosted via the website, not via YouTube. The links will be hosted via website. And then we'll do monthly sessions, which are free for members. So do sign up there, medsyncltd.com/resources. And we'll see you next time.